Good evening, Namaste. Welcome to the CCI webinar. Greetings from Chess Council of India. Today, Thursday, yet another special webinar. First of all, I thank all the CCI leaders. I am Dr S Jayaraman. I am a consultant pulmonologist working in Apollo First Med, Bilroth Hospital, and MGM Healthcare. I am from Chennai. Today's webinar topic is a very interesting topic. The topic is metallic lung diseases. I thank the CCI team. Every Thursday, they are choosing a different kind of a topic, no repetition at all. So each and every Thursday, we are amazingly chosen the moderator and speaker. I thank our team of CCI leader, Dr. CCI Chairman, Trustee, Dr. N.S. Krishna sir, Dr. Narayana Pradeepa sir, and the CCI National President, Dr. Ashish Dubey sir, and CCI National General Secretary, Dr. Anil Maske sir, and the CCI Webinar Coordinator, Dr. Chennai, and the leaders of CCI, Dr. Atri Gangopadhyay, Dr. Shivani Swami, and Dr. Kirat, and other leaders for the wonderful job. Now we are marching towards the 5th year. More than 4.5 years, successfully every Thursday night, 8 to 10, we are doing a wonderful webinar program, pan-India level. This is the beauty of the Chess Council of India. I thank the team captain under Dr. Krishna sir guidance. Thank you. Today we are going to have the different kind of topic, metallic lung diseases. This topic is a very keen topic. So as a specialist, we have to go in detail. So any patients come to us, we can have a large difference of diagnosis. We have to pinpoint the diagnosis. Nowadays, we are all practicing in an era of precision medicine. So we have to diagnose precisely and treat precisely to prevent unnecessary morbidity and mortality. The topic today is the metallic lung diseases. Under this heading, we have 4 important highlighting points. Number 1 is to understand the immunopathogenesis of heavy metal exposure to respiratory system. Number 2, understand the chronology of exposure and the clinical presentation. Third highlighting point is the awareness on the preventive measures to implement in the high-risk individuals. And fourth is helps you to design the treatment plans, including management of end-stage lung diseases. These are the main topic of introduction. So the flow of the event will be, we have a 2 back-to-back presentation by the eminent speakers, and we have the panel discussion. So the topic of metallic lung diseases, you all know very well, heavy metal exposure may contribute to inflammation in the lungs via increased oxidative stress, resulting in a tissue destruction and obstructive lung function. The fumes or gaseous forms of the several metals, example cadmium, manganese, mercury, nickel, zinc chloride, vanadium pentoxide, may lead to acute chemical pneumonitis or pulmonary edema, or to acute tracheobronchitis. So acute exposure can cause a variety of symptomatology. According to the Agency for Toxic Substances and Disease Registry, lead, cadmium, mercury, and so on are the top priority contaminants. Heavy metal exposure to the environment may adhere to fine particles in the air and cause asthma or environmental allergens, that is the metal allergens. A particular form of interstitial lung disease called a hard metal lung disease, including a giant cell interstitial pneumonia and pulmonary fibrosis. The clinical and the radiological features of giant cell interstitial pneumonia sometimes can mimic the hypersensitivity pneumonitis. There are a variety of presentation. So we need to have a proper diagnostic tool, meticulous history examination, and appropriate investigation to confirm the diagnosis of the lesions. With this, may I introduce our esteemed panelist. May I introduce Dr. Manoj Yadav. Manoj Yadav is the head and consultant pulmonologist at Kailas Hospital, Center for Respiratory Care, Vadodara, Gujarat. Dr. Manoj is a former honorary associate professor at Pramukh Swami Medical College, Karamsad, Gujarat. Dr. Manoj is the founder and president of Association of Chest Physicians of Vadodara. Selected for oral and paper presentation at national and international conferences, awarded for the best presentation at NAPCON 2016 and NAPCON 2019. The publications are an early Indian experience with the benralizumab, a compendium on severe asthma cases, a case series. Welcome, Dr. Manoj, sir. May I welcome Dr. Sunayana Dubey, TB and chest specialist, Pushdeep Hospital, Tottigaon, Devas, Madhya Pradesh. Madam did MBBS from NSCB Medical College, Jabalpur, and Diploma in TB and chest disease from MGM Medical College, Indore, in the year of 2011. Worked at MRTB Hospital and Indore Chest Center, Indore, District Hospital, Indore, and worked in Ruby Hall Clinic, Pune. Currently running a own Pushdeep Hospital at Tottigaon, Devas, Madhya Pradesh. Madam is a specialist in COPD and bronchial asthma. Achievements are presented a poster at International Conference on Middle Lobe Syndrome and a poster on COPD in non-smokers. Welcome, Dr. Sunayana Naik. May I invite Dr. Richa Mittal, MD, DM, Pulmonary and Critical Care Medicine. Madam is currently a consultant, pulmonary and sleep medicine, working at Sir H.N. Reliance Foundation Hospital, Mumbai. Madam has received a Iyer, European Respiratory Society Fellowship on Rigid Bronchoscopy at Marseille, France. Best Oral Presentation Award won at NAPCON, Kerala, 2019. Best Research Award won at NAPCON, Jaipur, 2015. And reviewer for journals like Breathe, Monaldi Archives, Chest Diseases, BMC, Pulmonary Medicine. Dr. Richa has presented 18 research articles and publications in peer-reviewed journals, and 2 chapters for practice updates in respiratory medicine by Elsevier publications. Welcome, Dr. Richa. Last but not the least, may I introduce and welcome Dr. Kapil Iyer, consultant transplant pulmonologist, Marengo Sims Hospital, Ahmedabad. He is a MBBS, MD, DNP Pulmonary Medicine, fellowship in lung transplantation from UK. As a first international student to receive the Medal of IP Pavlov in Ryazan, Russia, dedicated fellowship in lung transplantation in Vidhansavi Hospital, Manchester, UK. He has a keen interest on all facets of lung transplantation with an aim of building up sustainable local programs in lung transplantation, and several publications in national and international, members of Indian Society for Heart and Lung Transplantation, Indian Chest Society, American College of Chest Physicians, ERS, Chest Council of India, and Indian Association for Bronchology. Currently working in a Fortis Hospital, heading the Department of Transplant Pulmonology, Mumbai. Welcome, Dr. Kapil Iyer. With these few introductions, may I invite Dr. Manoj to present the topic of a very interesting. There are 2 presentations. First, may I invite Dr. Manoj to present on immunopathogenesis of heavy metal exposure and lung, followed by Dr. Kapil will be presenting clinical presentation of heavy metal exposure. Now over to the first presentation by Dr. Manoj, immunopathogenesis of hard metal exposure and lung. Over to Manoj, this is stage of. You can take.
Good evening, everyone. My sincere gratitude to CCI for giving me an opportunity to talk on this forum. And my sincere thanks to Dr. S Jayaraman sir for his kind words of introduction. The topic given to me is immunopathogenesis of heavy metal exposure and lung. Heavy metals are generally defined as metallic elements that possess a high specific density above 5 grams per cubic centimeter with an atomic weight more than 40.04. Some metals such as zinc, selenium, manganese, cobalt, iron, and copper are essential trace elements and beneficial for various physiological and biochemical progress in the living organisms when in adequate amount. However, excessive supplementation of such metals may become noxious to cellular and tissue functions. Other metals such as lead, cadmium, mercury, arsenic, nickel, and chromium are deleterious to biological organisms even in minor quantities and are therefore classified as non-essential metals. Heavy metal exposure can have serious effects on lung health, and the mechanisms behind these effects involve complex immunopathogenic processes. Heavy metals are commonly encountered in industrial emissions, vehicle exhaust, contaminate water, and certain foods. They can enter the body through inhalation, ingestion, or skin contact. Some criminals have used some heavy metals to poison their victims too. The pulmonary disorders due to metal exposure, let us understand certain general principles. The respiratory system is not necessarily the only or the principal target for the toxicity of metal compounds, even when their entry to the body is by inhalation. For example, chronic inhalation of lead, mercury, or manganese may lead to systemic effects such as neurological damage without leading to serious respiratory damage. Lung disease found in people who are occupationally exposed to metals is not necessarily due to these metals. For example, smokers we find in industrial workers. They may have COPD and it may or may not be related to the exposure to heavy metals. Exposure to metals is not confined to workers involved in metal mining or metallurgy. For example, cobalt-induced fibrosing alveolitis and bronchial asthma have been described in diamond polishers who used cobalt-containing polishing disc. Then we have non-occupational exposure, like housewives having berylliosis because of beryllium workers who brought factory dust to their homes, and then lead-laden color paint chips ingested by children cause lead toxicity. Understanding the properties of heavy metals is important. So the metalloids tend to form covalent bonds, making them show toxicological properties. The two most important consequences of this property are that they can bind covalently with organic groups. Hence, they form lipophilic ions and compounds. And they can generate toxic effects when they bind to non-metallic elements of cellular macromolecules. Due to becoming lipophilic, the metalloids distribution within the biosphere and their toxic response vary from the action of simple ionic forms of the same element. Metals cannot be broken down and are non-biodegradable. Organisms may detoxify metal ions by hiding the active element within a protein or depositing them in intercellular granules in an insoluble form to be excreted in the organism's feces or for long-term storage. When the heavy metals are swallowed or inhaled into our bodies, they bioaccumulate in our system. Thus, they are classified as dangerous. This bioaccumulation causes biological and physical complications. Let us understand the mechanisms of toxicity. There are basically two: cellular and molecular interactions and disruption of cellular functions, and both have different pathways. So, cellular and molecular interactions may act by oxidative stress. So, heavy metals can generate reactive oxygen species, that is ROS, that cause oxidative stress leading to cellular damage. This stress can damage DNA, proteins, and lipids, contributing to inflammation and cellular apoptosis, that is programmed cell death. Then we have inflammation. Heavy metals can directly activate inflammatory pathways. They interact with cellular receptors and signaling molecules, promoting the release of pro-inflammatory cytokines, that is TNF-alpha, IL-6, IL-1 beta. This results in an inflammatory milieu in the lungs, which can cause tissue damage and fibrosis over time. We have NK-kappa B pathway. Heavy metals can activate the nuclear factor kappa B pathway, which plays a central role in regulating immune responses and inflammation. Persistent activation of NF-kappa B can lead to chronic inflammation and tissue damage in the lungs. Mitogen-activated protein kinase pathways, including ERK, P38, and GNK, are also involved in the cellular response to heavy metal exposure. Activation of these pathways can contribute to inflammation and cellular stress responses. Then we have toxicity because of disruption of cellular functions. There is alteration of enzyme functions. The heavy metals can inhibit or alter the function of crucial enzymes involved in cellular metabolisms and defense mechanisms. Then the cellular functions can be disrupted by impairment of cellular repair mechanisms. So metals like cadmium and arsenic interfere with cellular repair processes, increasing susceptibility to chronic lung disease. This is a graphical chart of how heavy metals can affect the nucleic acids, the lipids, and the proteins, leading to carcinogenesis, cell damage, and cellular function loss. Let us now understand the impact on immune system. There is immune cell dysfunction. So heavy metals can affect the function of immune cells such as macrophages, neutrophils, and lymphocytes. This dysfunction can impair the body's ability to respond to infections and clear damaged cells. The T cell response. Heavy metals can affect T cell functions, including differentiation and activation. For example, lead exposure can skew the T cell response towards a Th2 type, which is associated with allergic reactions and chronic inflammation. This can exacerbate conditions like asthma. Autoimmunity. So there is molecular mimicry, that is, heavy metals can induce autoimmune responses through mechanisms such as molecular mimicry, where metal-adapted proteins resemble self-antigens. This can lead to an immune response against the body's own tissues, including the lungs. Then we have autoimmune diseases, like chronic exposure to heavy metals has been linked to autoimmune diseases such as systemic lupus erythematosus, that is SLE, and rheumatoid arthritis, which can include lung manifestations. Let us now come to some diseases. So chronic respiratory diseases. Long-term exposure to heavy metals, especially cadmium and arsenic, has been linked to COPD, which is characterized by persistent airflow limitation and chronic inflammation of the airways. Heavy metal exposure may also contribute to increased oxidative stress, disruption of barrier mechanisms, and impaired DNA repair, resulting in inflammation and tissue destruction in the lungs, manifesting clinically as obstructive lung disease. There has been a significant association between FE1 by FVC ratio and lead and cadmium levels in the blood. Asthma is another disease which can be caused by complex platinum salts, nickel, chromium, or cobalt, presumably on the basis of allergic sensitization. Asthma in such patients is due to immunoglobulin E, that is IgE-mediated mechanism. Then interstitial lung disease, chronic inflammation caused by heavy metals can result in lung fibrosis. This is characterized by the accumulation of intracellular matrix components such as collagen, leading to scarring and loss of lung function. Fibrotic changes are often seen in patients with silicosis and asbestosis, which are related to mineral dust exposure, but can also be influenced by heavy metals. Lung cancer. Some heavy metals, particularly arsenic, chromium, and nickel, are classified as carcinogens. The mechanism of carcinogenesis is either genotoxicity or promotion of tumorigenesis. So, genotoxicity. Heavy metals can cause genetic mutations that lead to cancer. This includes direct DNA damage and interference with DNA repair mechanisms. Then we have promotion of tumorigenesis. Chronic inflammation and oxidative stress induced by heavy metal exposure can create an environment conducive to tumor growth. Take-home messages and references are heavy metal exposure can lead to lung disorders and involve various pathways for pathogenesis. Common lung disease like asthma, COPD, ILD, lung cancer can be due to heavy metal exposure, and a detailed exposure history is paramount to suspect the same. These are some of the references. I've just mentioned two, but there are multiple references when you Google it. Thank you very much.
So, hello everyone. Hello, my CCI family. First of all, really, Dr. Jayaraman sir, excellent start. And, it is so difficult to follow up after the excellent talk given by Dr. Manoj bhai. And at the outset, let me also thank Dr. N.H. Krishna sir, Dr. Narayan Pradeep, Dr. Atri, Dr. Vijay Kumar Chenam Chetty, Garu, all these names which are instrumental behind not only the formation of CCI, but also, these regular academic activities. And also a very big thank you to Dr. Anil Maske and Dr. Ashish Dubey. So I'm going to follow up and very briefly touch upon this topic, which is what exactly do we see clinically in heavy metal exposure. And obviously all of us, including the panelists, will be having a very detailed discussion with regard to heavy metal exposure. So my outline very simply is I'm just going to first define what exactly are heavy metals. Is there any sort of a classification which is available? Thirdly, what exactly are the sources of heavy metals which we see in our atmosphere? And are they man-made? Are they natural? And, I'm going to talk about not only the pulmonary. I mean, I know that all of us are pulmonologists and this is primarily a platform for pulmonologists, but I'm going to be talking about pulmonary as well as extrapulmonary manifestations. And in the end, I'm just going to touch up on what exactly are the diagnostic criteria and when we must consider that a patient might be having heavy metal exposure induced diseases. Okay, so first definition. Now, obviously, heavy metal, it's a very broad term, and if you see different sources, you will have different definition. Okay, but we need to pay attention to the word that is heavy. Okay, so it is actually a group of naturally occurring metallic elements which have got high molecular weight. And how do you define high molecular weight? When you compare it with the molecular weight of water. Okay, so all these elements which have got a molecular weight which is more as compared to water, that is when you define it as a heavy metal. Now, at low concentrations, obviously, all of these metals are also essential for the well-being, for the normal physiological functions of the body. You know, all of us have got these medications, which contain, iron, zinc, and copper, and manganese. We all know this, especially, critical illness, polyneuropathy, and also we know that these are essential elements. However, slightly increase in their concentration is when we really start thinking about diseases. And there are some of these heavy metals such as arsenic, cadmium, lead, mercury, which unfortunately in the human body serve no biological role. Now, as far as classification is concerned, again, if you actually see the classification, there are different types of classifications amongst the heavy metals, also based on their weight, based on the presence, based on their source. You can get a lot of classifications. But what I really liked is this one, this one chart which I am showing and displaying on the screen, that out of all these heavy metals, based on the danger to the human body, this classification is a very simplistic look at that. And if you look at the blue shaded, the rectangles, the last one, you can see, and a very special importance is given to these 4 heavy metal elements. So this is lead, mercury, arsenic, as well as cadmium. So these are 4 out of the entire family of heavy metals which really have a very high degree of toxicity. And the characteristics of these are given in the last 3 boxes. So first is these are non-biodegradable, so elimination of these elements is really difficult. Second, they don't restrict themselves only to one organ system, so they actually affect multiple organ systems. And third is they do unfortunately have carcinogenic properties, so you are actually looking at development of a lot of cancers with exposure to these elements. Now, as I mentioned previously, what exactly are the sources? And it's really difficult, because if you actually think, we are just surrounded by heavy metals. So a lot of naturally occurring sources are also present, and a lot of man-made sources. What exactly are the natural ones? So all the agricultural activities, volcanic eruptions, these are places where you get naturally occurring heavy metals. What are the man-made ones? So all the industrial effluents, you've got biomedical waste, you've got these power plants, you've got, and there are certain occupations, because we know that the Earth's crust contains a very high concentration of these heavy metals. So anything which disturbs all of this can give rise to a huge source of these elements. So, activities such as mining, and you've got these electroplating, so coating with lead, it can be a source of heavy metal exposure. Now, clinical manifestations. Now, really, when I was reading up about what are the clinical manifestations, and first, because all of us are pulmonologists, so I first thought, let us look at, very briefly, because we'll obviously be having a detailed discussion about this, what exactly from the respiratory system can be involved. And I was actually surprised, because if you see, right from the nose up till the alveoli, it actually can involve each and every component of the lungs. Okay, so this box I've just given because it's just very simplistically looking, but if you think about this, the upper respiratory tract, so it actually starts with inflammatory changes, simple rhinitis, pharyngitis, laryngitis. In fact, some exposures will also give rise to damage of your nasal cartilages. Okay, as we keep going down, the entire airway is something which can be affected. So you've got reversible airway disease, something like brass fumes. These are disorders which can also mimic asthma, and you unfortunately prolonged exposure to these elements can give rise to permanent damage of the airways. And that is when you actually present with symptoms and signs of chronic obstructive pulmonary disease. Infectious are also quite common. So your upper respiratory or lower respiratory tract infections, because obviously they do damage at a micro level. And we all heard, Dr. Manoj Bhai's talk as to how exactly is the mechanism of damage. And, also exposure to these elements can give rise to full-blown pneumonias. And, we must pray that these patients don't develop bilateral pneumonias, which might progress into ARDS, because then the picture completely changes. Parenchyma, of course, you've got spectrum of interstitial lung disease. Now, I'm using the word spectrum because there are also, bilateral, just diffuse nodular opacities which are involved. Unfortunately, some of the diseases can progress to PPFs and honeycombing appearance on your lung parenchyma. And last is something which I had previously mentioned, which are mitotic changes. So, lung cancer obviously is very high on our list when it comes to pulmonary manifestations of heavy metal. And if you actually look on the other side, like I mentioned, one of the main effects of the heavy metal actually are extrapulmonary. So if you just see the human organism right from top to bottom, so you've got these systemic effects, these prodromals, you've got your chills, fever, pain, myalgias, your brain. So you can start with encephalopathy, cranial nerve involvement, yellowing, watering of your eyes, you get metallic taste in your mouth, your liver, you can have transaminitis ranging to liver failure, yellowing of the skin, your intestines can get damaged. Some of these kidneys can be affected. You can actually suffer from kidney shutdowns. And obviously, you've got even your circulatory shocks as well as gastrointestinal involvement in the form of vomiting, nausea, abdominal pain, burning sensation. And also, neuropathy is a very, very important manifestation of the exposure of some of the heavy metals. So, quite honestly, every single system can be affected. And the list of differential diagnosis actually is really huge. And it's a very difficult job actually to diagnose a patient who's suffering from heavy metal exposure. So, so this also, I found this online, which, very quickly gives when exactly in clinical practice should an analysis of toxic elements, be considered. Obviously, if you look at point number 5, this depends on your history. So if you do have a history of elemental exposure, plus certain combinations of your clinical presentation, that is when you need to have a very high suspicion of, heavy metal exposure and disease. So first is renal disease of unexplained origin. Second is bilateral peripheral neuropathy. Third is any acute changes in the mental function. Fourth is an acute inflammation of the nasal and or laryngeal epithelium. And obviously the 4 of this on the background of a history of elemental exposure. So as you can see, the primary effect actually is extrapulmonary. The only one in the pulmonary is nasal and laryngeal cartilage and epithelial inflammation, which can be seen in these patients. Now, I'm just coming, this is the last slide. What exactly are the diagnostic criteria? Now, remember, diagnosis of elemental toxicity requires demonstration of all of the following factors. So first, you must have an evident source of elemental exposure. Second, obviously the patient must demonstrate signs and symptoms which are typical of the element. So for example, if you've got lead, you will have a certain clinical picture. If you've got beryllium, you've got like a sarcoid like picture, which is presenting. If you've got cobalt exposure, you've got something which is known as a hard metal lung disease. So every single element will be associated with a particular clinical manifestation. And third, which is the most important, you need to have a tissue appropriate element concentration. So sometimes it can just be blood, sometimes you need biopsies. In cases of hard metal, sometimes you need lung biopsies which can show cobalt exposure. Look at the last statement. If any one of these features is absent, it is very difficult for you to make a conclusive diagnosis of elemental toxicity. Okay, so we will obviously be discussing all of this more in detail as the panel discussion goes on. So thank you so very much, and I'm really looking forward to an excellent discussion on a very important topic, that is heavy metal exposure and its manifestations on the lungs. Thank you so much.
Very fantastic two presentations. First presentation by Dr. Manoj, beautifully presented on immunopathogenesis of heavy metal exposure and lung. So beautifully explained the mechanism behind how the lung fibrosis, the mechanistic lung damage occurs of the exposure of acute and chronic metallic exposure. And followed by, we had a wonderful crisp and clarity lecture by Dr. Kapil, clinical presentation of heavy metal exposure, pulmonary and extrapulmonary manifestations, and the role of interventions to play, how to diagnose. So these presentation needs a high index of suspicion. So the similar kind of presentation we have seen almost all kind of diseases like asthma, exacerbation, COPD exacerbation, malignancy, infections, pneumonia, and all. So we'll discuss in detail during our panel discussions. So I request all the audience delegates kindly post your questions in the chat box, so we'll appropriately address that. So we'll begin the panel discussion. So we'll begin with the basic questions about what is metal, and the definition of a heavy metal. To start with, may I ask a question to Dr. Kapil regarding the definition of a heavy metal. What all does it constitute? The basic questions, Dr. Kapil.
So thank you so much. It's a very lovely question. And, the first thing which I actually noticed is the first, I think, second slide of Dr. Manoj Bhai, and in fact, the first slide of mine, if you notice, both of us gave a slightly different definition of heavy metals. And that is precisely what exactly is happening, because you are unable to come to a proper, concise definition of what exactly is the meaning of heavy metals. But the more acceptable definition is what was written in Dr. Manoj Bhai's slide. There's a proper weight parameter and atomic weight parameter, which is 5 gram per cubic meter per cubic centimeter, which is actually considered to be the definition of heavy metals, stressing obviously on the fact that it needs to be heavy. But once this was actually defined, there were more further elements which were found, which were having actually a weight lesser than this, which was also giving rise to problems. The most famous example that I can give is actually beryllium. The weight of beryllium was just 3.2. So it was not exactly fitting into this criteria. So we've got the International Union of Physics and Applied Chemistry, which very lately has mentioned that the term heavy metal by itself should be interpreted as a misnomer, and the more appropriate terminology should actually be toxic metals, because as we know, some of these metals are essential for the human body and the physiology. It's only some, especially in greater concentration, which actually gives rise to toxicity. Now, 4 basic elements which are really toxic are lead, cadmium, arsenic, and mercury.
Thank you. Very nice definition of metal and what are the constituents of metal. So you're given two kinds of thing. So metal means is one of the our friendly thing. Other one is the toxic. So cadmium and other lead and all. If you go beyond the limit, it may cause a lot of damages to pulmonary and extrapulmonary. Thank you, Kapil. And next, the same kind of thing. So what are the primary sources of heavy metal exposure that can lead to lung infestation, and how can individual minimize the risk? This is the question to Dr. Sunayana, ma'am. Yeah.
Thank you very much, sir. Actually, the primary sources which are leading to this lung infestation, exposure of lungs to heavy metals, are mainly the industrial emission. In these factories and manufacturing the plants release the heavy metals such as lead, arsenic, and cadmium and mercury into the air, which is inhaled by the heavy metal, these workers and nearby residents near the factories. And mining and smelting operations, where these ores are removed from the earth crust. These are mainly related to arsenic, lead, cadmium, which are in high concentration in the atmosphere there and affect both the workers and their surrounding communities. Then in the common peoples, which is the vehicle emission. Mostly the older vehicles are related to lead emissions in their smokes, and our well-known product, the tobacco smoke, which is the most common enemy of our lungs, is responsible for the cadmium and other high toxic metals, and this affects the primary smokers and the secondary smokers also. Then environmental pollutions can occur also from the soil and the water containing high metals, high amount of these metals, which in the windy atmosphere can become airborne and go into the lungs. And sometimes there may be high concentration of these heavy metals in the cosmetics, paints, and household cleaning products also, which can affect the lungs. And we can minimize our exposure by using this personal protective equipments in the industrial area, mask and all, and other work safety precautions, like we can use. Sorry.
Yeah, ma'am. You can proceed. You can on the
workplace safety by ensuring proper ventilation and air filtration system in the workplace, and avoiding tobacco smoke, quitting the tobacco smoking and avoiding the secondary smoking, and regular monitoring of environmental area and exposure to the people residing near the industries.
Thank you, Sunayana ma'am, for this wonderful answer. Primary sources of heavy metal exposure. So it can present in the environment, both indoor and outdoor pollution. So a lot of industries, emissions, industrial workers, industrial air pollution. There are a lot of things which contains a lot of metal exposure. So how to prevent it? We have to act the industrial act to be strict enough to, then only we can achieve. In our country, we are all a highly populated, number one highly populated country. So a lot of in the small industries level, it's very difficult to adhere all the rules and everything and all. That's why a lot of exposure, which leads to so many problems we are facing day to day. Thank you, madam. May I go to the Dr. Richa, ma'am, regarding the clinical presentation. So when do you suspect? So when should metal toxicity be considered as a differential diagnosis in a patient? What aspect of the patient history might raise suspicion, including details about the occupational, drug history, environmental history, and oxygenal exposure? So, Richa.
Good evening, everyone. So by now, we have already established that taking history of occupational history specifically is crucial for reaching a diagnosis. So if that is missed, you tend to miss the diagnosis of many occupational lung disease. So in the history also, when we are asking about the occupational history, it is very important for us to take not just about the present job, but also about the past jobs and the duration that the patient has been there for that particular job. If the patient knows about what kind of exposure, what kind of metals he is exposed to, chemicals he is exposed to, that's well and good. But otherwise, you tend to ask what kind of occupation, what kind of work he was involved in. Then when you have established that he was exposed to some kind of metal exposure at his work, then it is necessary that you try and see whether the temporal relation, whether the symptoms got before or after when he joined the job, or it got aggravated. The symptoms got aggravated when he went to the work. So that is crucial when you are trying to differentiate whether it is work induced or work aggravated symptoms. Also, there are many diseases that we'll talk about later that gets aggravated when the patient is on the job, and then they get better once they are off the job. So that temporal relationship is very crucial when you're taking the occupational history. Also, what kind of, as ma'am highlighted, what kind of equipments, what kind of protective equipments were being used at the job. So whether they're wearing masks, whether there are any PPE being used, and what is the health and what are the diseases of other workers at his place. So that can also help you to find a relationship. So that is about the occupation. Now, as Manoj sir highlighted in his talk, that not just patients, not just people who go to that particular job, they are at risk, but people like in family, if someone else is going for that occupation where he's exposed to metal, those are also at risk. Housewives or other people who are, especially children, they are also at risk of metal toxicity. So always try to find a relation if anyone else is working in a metal industry, anyone in the family. Or if the patient is living in an area with something like industrial belt where the exposure can be high, the polluted area, that also try and ask if there was any accidental exposure where there are high level of fumes or high level of toxic metal fumes the patient can be exposed to. So see how the symptoms were, whether they were acute, whether they were chronic. So try to understand that. So, and as Dr. Kapil highlighted in his talk, that when there are multiple symptoms, both pulmonary, extrapulmonary, so always when you are taking history, ask for the other systems history also, whether there are any ulcers, whether there are any nail changes, skin discoloration, metallic taste of mouth, neuropathy signs, or any history suggestive of CNS involvement or CVS involvement. So these are certain. Definitely what raises the suspicion is when you have a documented exposure history. But even if you don't have, there are multiple other signs and multiple other points in your history that can point towards occupation related, or maybe when the patient is exposed to metal related.
Thank you, Richa ma'am, for this wonderful insight about the industrial exposure. That is clinical high index of suspicion is very, very important. We have to ask the detailed occupational histories, what kind of job, what kind of exposure, whether acute or chronic, and whether the person is wearing the gadgets or not. So these are all the queries. The detailed history is paramount important in the diagnosis of these kind of metallic lung diseases. Thank you, ma'am. So I'm moving to Dr. Manoj sir regarding how does heavy metal exposure influence the development or exacerbation of the obstructive airway disease like asthma and COPD exacerbation? Dr. Manoj sir. Sir, you are muted. Unmute, sir.
Yeah.
Manoj, sir. Yeah.
Sorry, my bad. So we already discussed about how the mechanisms of development of disease is there. But to give briefly again, so heavy metal exposure is associated with a decline in lung functions in COPD patients. And there have been studies which show that cadmium levels above particular levels of 0.45 micrograms per liter increases the risk of COPD increases significantly. And there is another study of 2012 which shows that there is a blood lead level concentration dependent risk of COPD development. If we talk of asthma, then heavy metals like cadmium, lead, and arsenic can trigger local airway inflammation and oxidative stress in the lungs, which may contribute to the development and exacerbation of asthma. Heavy metals can also attach to the fine air particles and act as environmental allergens. Apart from inflammation and oxidative stress, long-term exposure to lead may be linked to immune system disorders in adults with asthma. And high blood level concentrations are linked to a higher level of active asthma and wheezing in children from age 6 to 11. These are findings which have been done and substantiated.
Thank you, Manoj sir. So usually, any case of OAD, obstructive airway disease like asthma exacerbation or COPD exacerbation, the common etiology behind the infective exacerbation, either viral influenza or the respiratory viruses or atypical viruses and rarely bacterial and all. So infective causes one of the important things. So apart from this metal exposure, working environment, so aggravation of this kind of a worsening of lung disease, already existing asthma and COPD, this kind of exposure will lead to the acute worsening of the conditions, which leads to lung attack, COPD exacerbation or asthma attack, we call it as. So nicely you put the word correctly on that. So heavy metal exposure is one of the differential diagnoses. You must keep it in mind. There is no fever, atypical presentation. One of the things we have to suspect is any metal occupational history is a very, very important thing. You have to rule out that. Thank you. So we'll move on to Kapil again regarding already you presented nicely about the pulmonary and extrapulmonary manifestations of the heavy metal exposure. Just to briefly highlight once again, what are all extrapulmonary manifestations of heavy metal exposure? Kapil.
Thank you, sir, for that question. So even in my presentation, as I mentioned, that actually, all of us are pulmonologists over here, and obviously we look after disease of the lungs, but these toxic metal exposures actually have got more predilection to affect, the extrapulmonary symptoms. And even Richa mentioned in her talk, that you're supposed to actually pay attention to a systemic evaluation. Now, I would just like to use two historical evidences, which was seen in Japan. You've got two diseases from there. One is known as Minamata and the other is known as Ikai disease. Both of them are symptoms of mercury and cadmium poisoning respectively. In Minamata disease, it was found out that there was an entire generation which had neurological complications ranging from ataxia to encephalopathy to neuropathy, combination of upper and lower motor neuron disorders, disturbances. And when they actually found out the source, the Minamata Bay is the area from which the people used to eat the fish, which was unfortunately contaminated with mercury. So these are all evidences, which gives rise to a neurological predilection for mercury. In Ikai, it was cadmium, again an industrial disease, in which the people had complete and accelerated osteoporosis and the complete bone deformity which was seen. Now, even when we are talking to our colleagues, we always jokingly say that how exactly to best remember tuberculosis is. Tuberculosis affects everything right from head to toe. It's the same also with toxic metal, as I mentioned even in my talk. So your CNS, your cranial nerves, your skin, your nose, your circulatory shock, gastrointestinal disturbances, and even kidney shutdown. So all of this are actually seen in different exposures of these toxic metals.
Yeah, thank you, Kapil. Wonderful. So the metal can cause head to foot all the part. It can damage the thing. And with the examples of mercury in the fish areas like Minamata and Hika areas and all, there are a lot of mercury poisoning because of this exposure. So it affects head to foot all the organs. So nice. And we'll move on to the Dr. Sunayana ma'am. What are the most common heavy metals that affects the lung health, and what specific mechanisms do they use to cause damage to the lung tissue, ma'am?
Especially most common metals which are affecting the lungs are the cadmium, which induces the oxidative stress, inflammation, and apoptosis in the lung cells, and it disrupts the alveolar macrophages, leading to impaired lung clearance and damage to the lung tissue. Then there is the lead, which is basically neurotoxic drug, neurotoxic metal, but it also leads to causes oxidative stress and inflammation in the lung tissue and contribute to the respiratory conditions like asthma. And arsenic is another drug, metal, which is mainly found in the smelting operations and mining, and it causes COPD in the lungs by the DNA damage and oxidative stress and inflammation. Mercury, after inhalation of the mercury vapors, it causes pneumonitis. It affects lungs directly and causing pneumonitis and bronchitis. And chronic exposure affects the cellular respiration and mitochondrial functions in the lungs. Then nickel and chromium, they are common in the industrial environments and cause respiratory irritations and allergic reactions, increase the risk of lung cancer by damaging the DNA and immune response alteration.
Thank you, ma'am. So common heavy metals are lead, cadmium, mercury, arsenic, chromium. These are the commonly common metals which leads to all the diseases. The mechanism behind is the oxidative stress inflammation, which leads to lung fibrosis. Mostly is sometimes reversible, sometimes irreversible changes, which eventually leads to chronic exposure, leads to respiratory failure and all. Okay, fine, madam. So move on to Dr. Richa, ma'am. Regarding what is a hard metal lung disease, and what are the clinical and radiological features associated with a hard metal lung disease? Richa, ma'am.
Yeah, so hard metal, we've been talking a lot about heavy metal. So hard metal is basically nothing but just tungsten carbide. It's a powdered form of tungsten carbide, which is mixed with cobalt, and mostly the cobalt is there, and there are other elements also, some other elements in minor amount. So what really happens, it's a hard that it is tough and durable, and that's why this compound is used for making parts for drilling or maybe cutting tools and grinding these tools, and something that is resistant to heat. So those machine parts it is used for, and that is where the people get exposed to when they are in such activities. And it is basically, when it comes to clinical, then it can give to this hard metal can give to something as upper respiratory tract irritation, also laryngitis, pharyngitis, and this is the toxicity happens because of the contact from the skin absorption. But when it is through the inhalations form, when the submicron, the ultrafine particles get inhaled, into the body. Then what happens, it can give to two forms, which is one is the diffuse interstitial fibrosis and other is something very similar to hypersensitivity pneumonitis. So in the hypersensitivity pneumonitis, the patient present clinically very similar to HP with subacute or insidious onset of cough, breathlessness, and fatigue, and these are the symptoms. And the radiologically also presents like HP with centrilobular nodules and mosaic pattern, and the head cheese sign can be seen. That is radiological, and you treat on the similar lines with you can remove the discontinue the exposure, and you treat with corticosteroids. When it presents with something like diffuse interstitial fibrosis, the clinical symptoms are similar. They are more chronic and it presents with cough, breathlessness. But what is characteristic is on the biopsy, if you see, there are giant cells. And Dr. Sharda shared today only on the WhatsApp group the classical histopathological this characteristic that there are giant cells seen in this particular form. And that's why it is also called as giant cell interstitial pneumonia. And these giant cells, basically, they are characterized as cannibalistic. They're engulfing each other in a bizarre shape form. And that is the characteristic thing. And if in some reports, it is also shown that if you do electron microscopy of this biopsy, you can also see the tungsten material, not the cobalt material, which is actually the causative metal, but the tungsten material can be seen on the biopsy, and that proves your diagnosis of the giant cell interstitial pneumonia. When we talk about radiologically, it presents very similar to UIP form, that lower lobes are involved, subpleural is involved, and architectural distortion is there. Rarely honeycombing is also there. Now this, in contrast to the HP form, this has bad prognosis and it usually progresses even after you remove the patient from the exposure. So it is very similar to UIP pattern, and that is why it has two distinct forms, and that is what is known as the hard metal lung disease caused due to the cobalt toxicity.
Thank you, Richa, for this wonderful insight into that hard metal lung disease due to tungsten, cobalt, and other mixture, which leads to sometimes it mimics the hypersensitivity pneumonitis and interstitial fibrosis. The main job orientation with the drilling and grinding industries, so which leads to a lot of problem, which leads to the giant cell interstitial pneumonia pictures. So clinically, radiologically, so we have to differentiate this from the meticulous history examination. So radiologically, it presents as a UAP pattern. So bilateral, subpleural, honeycombing, fraction bronchiectasis, everything will be there. So we have to prognosis wise, this is a very bad when you compare to HP and all. So we have to treat it meticulously. Even after removal, you said the disease, prognosis is very bad. This kind of giant cell interstitial pneumonia and all. Thank you, ma'am. So I'll move on to Dr. Manoj regarding what are the potential therapeutic strategies to mitigate the effects of heavy metal exposure on lung immunity. Manoj, sir. Sir, you are muted. Unmute, sir. Please unmute.
Yeah, sorry. So this is very interesting, the therapeutic strategies while going through the literature. So although we know that there are chelating agents, like chelation therapy is the primary treatment used to reduce the toxic effects of heavy metal exposure and its toxic side effects. So chelating agents, they bind the toxic metal ions and form complex structures that are easily excreted from the body and removing them from intercellular and extracellular spaces. The chelators mobilize metals in tissues that mediate their excretion either through the kidneys in the urine or liver in bile. Then second group of medications or therapeutic strategies is using antioxidants. So free radical scavenging, chain-terminating antioxidants such as vitamin E and C are chemicals with large resonance stabilized electron clouds that work as electron donors, and vitamin C works through the activation of biological antioxidant defenses such as GSH-linked enzymes. There is another astaxanthin which prevents oxidative stress induced by the cadmium, copper, and cobalt and alleviates cell damage caused by these metals. Selenium and lycopene have been reported as antioxidants against the toxicity of heavy metals such as cadmium, lead, and chromium. The most interesting therapeutic strategy is the use of probiotic yogurt, our simple yogurt. Now, they have found that there is a study which used yogurt containing the heavy metal resistant strain, Pediococcus acidilactati GR1, which was found to be effective and affordable approach for combating toxic metal exposure to the protection of indigenous gut microbiota in humans, resulting in a faster decrease in copper, that is up to 34.4%, and nickel 38.3% levels in the blood. There is another flavonoid glycoside by the name of gossypin, which is actually isolated from Hibiscus vitifolius. Hibiscus is a common flower, and this Hibiscus vitifolius is a flower in Chinese medicine. It has got antioxidant and anti-inflammatory activities and has shown considerable promise for improving recovery in animal models. So I think our humble yogurt, vitamin C, vitamin E, they are found to be of good therapeutic use in patients exposed to heavy metals. Of course, chelation is a lot of work has been done on chelating agents also, different type of chelating agents.
Thank you, Manoj. The treatment strategies for heavy metal exposure, starting from chelating agents and simple yogurt, which has probiotics, and vitamin E and C and antioxidants, plays a major role in preventing or just we can reducing the prolongation or reducing the fastness of the disease. So this are the chelating agents. One of the important thing you said, right? Chelating agents.
I'd like to add one more thing.
Yeah, please.
So these are the therapeutic strategies in heavy metal exposed patients. But what has been used is uses different types of fungus to actually decrease the absorption of the heavy metals into the plants. So they are using that as a preventive measure to decrease the levels of the heavy metals being absorbed by the plants and being bioaccumulated in the body of organisms which eat them. So that is like a preventive therapy. So a lot of work is going on into that. And then there are other strategies where they use different types of crops to decrease the absorption of heavy metals into one crop with the help of other crop.
Thank you. There is a lot of pipeline treatment for the
even for prevention.
Yeah, prevention. Treatment as well as the prevention. Thank you. Thank you. So now I'll move on to Dr. Kapil. See, nowadays we have a lot of industries. In India, there is a highly populated country. There are a lot of wearing a mask and other things. A lot of small-scale industries and all. They're not adhere to the proper rules and regulations. So without the proper gadgets, they work and expose to a lot of things and all. So regarding the Indian small-scale industries, with examples of heavy metal exposure toxicity. So Kapil, can you throw some light on this?
Thank you so much, sir, for that question. And I was, in fact, just about to start my answer also with the way that you've introduced. See, our country, we are 140 crores. And, we've got a lot of these small scale industries, which is actually prevalent in different states. And, people from a particular state know that from which region, what industries are prevalent. Now, why this knowledge is important is because when we have got patients coming from specific areas, we need to know what sort of areas, for example, certain areas will have mining activities, there are certain areas which will have a particular, history of exposure of some toxic metals. So that is extremely important for us to know clinically. There might be occasional patients which might also give misleading occupational histories because 90% of these industries are unregulated. So there might be a bit of guarding, on the part of the patients. I would just like to give one example. Manoj Bhai actually in his talk had actually mentioned about this. So when I was doing my post-graduation, we had seen a particular patient who presented to us as interstitial lung disease. But when we asked his occupation, he was a diamond polisher. So, sir had mentioned that, the plate which is being used is actually, that is emits cobalt. But sir, actually, in this patient, we asked him, so he had mentioned that they've got a particular machine in which the diamond is kept in the center and it rotates at very high speed. And they have a black color powder, which they keep pouring from top. So this powder is actually responsible for giving the shine on the diamond. So we asked him to get the powder. And when we examined it, it had an abnormal concentration of cobalt. So we have actually even published this data. The problem is he unfortunately did not allow us for a biopsy. He gave a negative consent. So what Richa mentioned, the tungsten and the giant cell, unfortunately we could not see. So this was a proper hard metal pneumoconiosis because of, cobalt exposure. So I am sure each one of us have got so many, examples, and small scale industries in India exist and they will always exist. And after seeing this patient, I decided that I will never gift diamonds to my wife.
Oh, yeah. So such a because of the unregulated industries, poor environment, there are a lot of multifactorial etiology. We are all struggling to get the disease and all. Okay. And move on to Dr. Sunayana, ma'am. So, what are the latest advancements in diagnostic techniques for detecting heavy metal accumulation in the lungs, ma'am? Dr. Sunayana, ma'am.
Yes. Thank you, sir. Nowadays, we can identify these with the exposure with the HRCT and MRI, which they can show the specific lung images in the these fields, and then we can assess the accumulation of these heavy metals in the blood or urine and other samples of the body of the patient. And bowel fluid also we can assess, measure the amount of fluid, amount of heavy metals. Then few biomarkers are we are researching for biomarkers which can analyze the heavy metal exposure in the lung damage. And one is the research is ongoing on the wearable devices that can monitor the exposure to airborne heavy metals and potentially detect the changes in the lung function and related metal accumulation. And other are these bronchoscopic biopsies, which can assess the damage and exposure to heavy metals.
Thank you, madam. Yeah. So, techniques. What are the diagnostic tools you mentioned, like imaging, mainly the chest radiograph and CT scan, HRCT? Like ILD workup is very important, and the confirmatory test may require sometimes the bronchoscopy and all. So, thank you for that. Similar question to Dr. Richa, ma'am. So, what is your approach? Diagnostic approach in these type of cases, like identifying metal toxicity as a cause of lung disease? Richa, ma'am.
Yeah, so I think we already covered, but still starting right from the history, where we start with a suspicion, and we are always asking that it should always be included in our protocol of asking the occupational history. And if you feel that when you were taking the occupational history that the patient might be exposed to metals at the work, and taking a detailed history about the past, present, job duration, and as I said, the temporal relationship. Also asking about other family members if they are going to any metal industries, or if the environment is where there are industry bells. So that is with the history that we talk about. And then when examination, we have stressed enough that not just pulmonary, we should look at the extra pulmonary signs also, right from skin. They are seeing any nail sign. Ulcers is very common, especially in beryllium. Contact dermatitis, beryllium, cobalt, both cause. And any other neurological signs, cardiovascular signs. So we should look at gingival and this bluish discoloration. So for lead poisoning, we should look at other signs also. So examining all these systems. Then definitely when it comes to labs and routine labs, definitely because anemia is with some heavy metal toxicity, it can come. Nephrotoxicity can seen with because of some heavy metal toxicity. So doing your routine labs is very important. Inflammatory markers can be raised because of the acute toxicity. And PFT. So if your patient is presenting acute, definitely you will not go ahead with the pulmonary function test. But if your patient has chronic symptoms, you do as an evaluation the lung physiology also, and you are trying to understand the PFT pattern. Because many metal toxicity, they present as obstructive airway disease, they can present as interstitial lung disease. So as he said that all airways, from airways to parenchyma, anything can be involved. So you try and understand the PFT patterns, and then the CT scan, and if needed, bronchoscopy, because definitely biopsy helps you to get in certain metal toxicity, especially beryllium, because it presents very similar to sarcoidosis. And before labeling the patient sarcoidosis, you ask for the occupational history, and if you anytime suspect, you should go ahead with, for not just biopsy, you always go ahead with, but you also ask your pathologist to see for any particular the pathologically if they are towards the beryllium. And we also do for beryllium lymphocyte proliferation test. I'm not sure where it is done in India, but it can be done on both bowel and serum. So that is something you try and do if you're suspecting, and urine samples or blood samples to look for the metal levels. So this is, and biopsy also proves, as I talked about in hard metal lung disease also, it proves your diagnosis. So, and bowel you do for in certain patients where you're trying to rule out other etiologies, especially infective etiologies. So you do everything from history to examination and PFT evaluation, radiological CT scans, and bronchoscopy and BAL on case-by-case basis.
Thank you, madam, for this diagnostic approach of the heavy metal exposure. Start from clinical, radiological, and pulmonary function and pathological. So sometimes we need to have the tissue. Tissue is the issue sometimes, so we can pinpoint the diagnosis. Sometimes the bronchoscopy biopsy or other biopsies are required to clinch the diagnosis. Thank you very much, ma'am. So move on to Dr. Manoj. Can you throw some light on what are the biomarkers? Discuss briefly about the biomarkers that correlate with the heavy metal exposure and associated immune responses. Manoj, sir.
Yes, sir. So I think a good part of it has been covered by Dr. Richa about biomarkers, especially blood, which are non-specific markers for inflammation. However, like to summarize, to briefly say that blood, urine, feces, they are used as they are being tested for biomarkers for heavy metal exposure. And it is important to understand the metabolic biotransformation and elimination of metals to interpret the metal biomarkers. For example, whole blood is a good biomarker for exposure of arsenic, cadmium, lead, mercury, and tin, but it is not a good indicator for barium, nickel, and uranium. Then total arsenic, urinary arsenic may reflect the exposure to both organic and inorganic arsenic. However, and hair and nails primarily reflect exposure to organic mercury, except in population exposed to high levels of inorganic mercury, such as in occupational and environmental setting. So here there will be difference between organic and inorganic mercury. And when selecting biomarkers, it is also critical to understand the exposure window. So most populations are chronically exposed to metals in the low to moderate range, yet many biomarkers reflect recent exposure only. Apart from blood, urine, feces, toenails and hairs are and teeth, they are upcoming biomarkers. So toenails are emerging biomarkers in this regard. They are reliable biomarkers of long-term exposure for arsenic, mercury, manganese, and selenium. Then similarly, teeth are increasingly used to assess the lifelong exposure to several essential and non-essential metals such as lead, including during the prenatal window. And other biomarkers like CRP, interleukins, TNF-alpha, lung tissue biomarkers, they are all non-specific and has to be interpreted in the context of proper exposure and clinical history.
Thank you, Manoj. A lot of biomarkers, specific and non-specific biomarkers. So we have to see in the blood, urine, feces, and the toenails, hair. So there are a lot of things we can pick up, whether it's arsenic exposure, inorganic or organic, and the manganese. So we can pinpoint lesions. So we have to analyze thoroughly. Sometimes we may require the tissue also to look into that, and CRP values, C-reactive protein, and interleukins. So non-specific only. So it can help in arriving at the proper diagnosis, etc. Thank you, Manoj, sir. So we'll see some chat box questions. Yeah, there are questions here. Dr. Prasanna Kumar from Karnataka is asking, Bengaluru, is asking the questions. Please share your insight on berylliosis and differentiation with the mercury. How to differentiate berylliosis and the mercury? Richa ma'am or Kapil, anyone can take.
Sir, actually, berylliosis and mercury exposure is very different. If the question would have been berylliosis and sarcoid, I would have understood because actually berylliosis and sarcoidosis go absolutely hand in hand. The clinical manifestations of both are exactly the same, and the number one differential of sarcoid actually is berylliosis. There is one major difference between the two, and that is sarcoid affects the eyes, but berylliosis never affects the eyes. And the second is, I think Richard already previously mentioned, you need to do the lymphoproliferative test, and I think it is done in Thyrocare. So that is a lab which is doing the test in which you can confirm berylliosis. Mercury per se has got more affinity to the central nervous system. Mercury poisoning. Remember I mentioned in Minamata disease. So, you've got ataxia, NCAF, you've got progressive, neuropathy. It's more like a combination of upper and lower motor neuron disorders which is seen.
Okay, thank you. Yeah. So, again, Kapil, Dr. Manoj mentioned about the chelating agents to remove the toxins from the lung or blood. So we have used the chelating agents to remove the toxins. So what are the chelating agents available for this issues, chelating agents with examples, and property of an ideal chelating agents.
Sir, I think sir, very beautifully put, in this treatment part about the chelating agents that, in certain heavy metals, it actually forms the mainstay of treatment. Now, sir, the word chelating actually has come from Greek. Very literally, it means holding like a crab. That's like the literal, the translation of this word. It's a Greek word, and it very much defines actually what a chelating agent needs to do. Now, if you actually see the textbook, there are some 6 or 7 properties of an ideal chelating agent. But as Dr. Manoj sir said, there are only 2 properties which we must see. Number 1, it should have, affinity towards the toxic metal. And second, the ability to form a non-toxic complex along with the toxic metal. Now, these are the 2 properties which ideally a chelating agent must have. Apart from that, theoretically, it should be very soluble in water. It should have a very high excretory rate. Obviously, it should be cheap, easy to administer. It is better if it is present in the oral and in the parenteral form. And it must be resistant for any changes in its structure, which is also known as biotransformation. I would just like to give 1 or 2 examples, like dimercaprol is the chelator which is used in mercury and arsenic poisoning. In terms of lead, actually it is EDTA, and in copper, which we see in Wilson's disease, penicillamine is actually the treatment of choice, which is like a chelating agent. So these are the examples of chelating agents.
Thank you, Kapil, for this wonderful insight on chelating agents. So the dimercaprol and the reagents usually commonly practiced in these kind of rare diseases. Okay, thank you. We'll move on to Dr. Sunayana ma'am regarding what are the recommended treatment options and strategies for managing heavy metal toxicity in the lungs, and how effective are they?
Sir, as Dr. Manoj and Dr. Iyer said, that one of the therapy is the chelation therapy, which we can remove these toxic metals from the body via chelating these metals. Commonly used metal, these are dimercaprol, EDTA, and DMSA, and they help removing these heavy metals by heating from the body. Then antioxidant therapy, N-acetylcysteine, vitamin C, vitamin E can help to reduce these oxidative stresses generated by these metals. Corticosteroids and anti-inflammatory drugs can help by reducing the inflammation and lung irritation. And people are developing fibrosis and all. By physiotherapy, breathing exercises can improve the lung function in chronic COPD-like conditions developing due to these heavy metals exposure. And lifestyle modification, change of job, and lifestyle modification like smoking cessation, avoiding the polluted areas, and maintaining diet rich in antioxidants and support to support the detoxification. And the effectiveness of these treatment depends upon the level of exposure and the duration of exposure to the body, and timeliness in the intervention, when we have intervened the treatment. And early detection and prompt treatment is generally results the better outcomes.
Thank you, ma'am. So the treatment for the toxic metal exposure or metallic lung disease due to the duration of exposure and the timing and how much level of exposure, a lot of treatment. So prevention and treatment strategies we have to strictly follow to prevent mortality. Thank you, ma'am. So move on to Dr. Richa, ma'am, regarding the metal fume fever. What are the characteristic features and prognosis of metal fume fever? Richa, ma'am.
So metal fume fever basically arises commonly in welders or anyone involved in galvanizing these metals like zinc, iron, chromium. So what happens when there's welding, the metal becomes super hot. So that vaporizes, condenses, and oxidizes, and that is inhaled by the person. And these are oxides of these metals which are inhaled, and they are usually of the ultra-fine size, and the particles which goes into your airways and the alveoli. So they are very common. So anyone who's involved in the welding, and sometimes the plumbers and the pipe fitters also, they also are involved in welding. So if you'll ask them, they're very commonly experienced by them. And it is also known as Monday morning fever. Why? Because it classically presents like when the patient goes back to work and then there is re-exposure. So the symptoms are more on Monday, Tuesday, and they actually fade away during the weekend, on the Saturdays, Sundays, on the off days. So that is a very important point that you need to ask in the history also. And they present with classical flu-like symptoms: fever, arthralgia, myalgia, headaches, metallic taste in the mouth, and wheezing, intense thirst, and tightness in the chest, and breathlessness at times. It is usually a self-limited disease. It's a mild disease, and when you are managing also, it's more of symptomatic management. So if there's fever, then just antibiotics, or maybe if you do PFT, there is bronchospasm, then you treat with inhaled medications, inhaled corticosteroids also. And usually patients do not suffer from hypoxemia. Rare cases, occasionally there are reports which shows that the patient can have a severe pneumonitis and there can be hypoxemic respiratory failure, but that's very rare. It's usually a very mild and self-limited disease, and very classically presents on the days when the patient go back to work with flu-like symptoms and fades away as the week ends and when the patient is away. So the symptoms usually, they peak over the few hours at the work and then they fade away in the next 24-48 hours.
Thank you, ma'am, for this wonderful insight on metal fume fever in welders, plumbers, and pipe fitters. The symptomatology, mainly the flu-like symptoms, the flu-like fever, otherwise called as a Monday morning fever. So very classical. Treatment is self-limiting. Symptomatic treatment, supportive management will control the disease. Thank you, ma'am. So move on to Dr. Manoj regarding how do heavy metals contribute to lung fibrosis or other structural changes in the lungs? Manoj, sir.
Yeah. So I think we have covered this earlier too. So I'll just briefly say that the major ways is, one is the heavy metals increase the oxidative stress in the lungs, which lead to the inflammatory reactions and damage to the respiratory system. Then there is an immune response, which causes disruption of the lung cell barrier functions, destruction to the collagen and elastin cross-linking, which again leads to emphysema. Cadmium and mercury are found to, exposure is found to damage the alveolar structures, causing fibrosis and inflammation specifically. And chronic lead and chromium and cadmium exposure trigger progress from emphysematous lung to fibrotic lung changes. So these are the changes which basically the oxidative stress, immune response, collagen damage, alveolar damage is how the lung fibrosis occurs due to heavy metals.
This fibrosis, is it reversible fully or partly, or irreversible disease, irreversible fibrosis? Because in COVID time, we have seen many cases of inflammation, fibrosis. Majorly, they, with the time factor, majorly it will reversible fibrosis. Where are the patients?
So what we see on the CT scan, maybe the reticulations may not be scarring totally. It may just be the starting of infiltrations, and that possibly may be reversible. But once it is totally scarred and fibrosed, that may not be reversible. So in some patients like goldsmiths who have worked with fumes, they have ILD, but they don't, their PFTs are normal, their 6-minute walk test is normal, and we don't need to give any treatment for them. So despite the scarring, they may not be having any physiological problems or even pathological problems. Unfortunately, when they have some respiratory infection, somebody does this thing, CT scan, the level is an ILD or sometimes IPF, and they start with antifibrotics, which is actually not required. So this may not be reversible totally, but they may not require treatment if the disease is not progressed.
Thank you, sir. So move on to Dr. Kapil. Kapil, you are a transplant pulmonologist, one of the leading in our country. So heavy metal exposure induced lung diseases. Is lung transplantation a possibility? Because lung transplantation, the major indications in our country, first is interstitial lung disease, ILD. Sometimes, rarely, this metal also can cause the ILD pattern and all. The second is COPD and the cystic fibrosis, bronchiectasis, there are a lot of things. So, in your opinion, in your experience, heavy metal exposure induced lung disease, is lung transplantation a possibility?
So first of all, I have a big smile on my face whenever we, discuss about lung transplantation, because that is my affinity towards this topic. So my answer is yes, but it's not so simple, in toxic metal diseases. Now, majority of the diseases, especially in the acute phases, obviously you're not going to think of lung transplantation. What I am interested is the sequelae, the extent of damage which is basically seen in these patients. And very rightly in the last discussion, you mentioned about the irreversibility of it all. Now, in my mind, I'm basically thinking of two confirmed things. I'm using the word confirmed here. So the first is, when a patient has got obstructive airway disease, which becomes fixed, irreversible, and we're thinking of chronic obstructive pulmonary disease, this is obviously one of the indications for lung transplantation, but you have to wait for quite some time. Your FEV1 has to start dropping to about 30%. Your board index minimum has to be about 5. That is when, you need to start having type 2 respiratory failures. Your PCO2 has to be around 55. That is when you start thinking about lung transplantation. The more frequent, and as you mentioned in our country, the most common indication is interstitial lung disease. So yes, we will definitely be having a low threshold, in fact, when there is an irreversible fibrosis which is seen in these patients. And it's not only us in our country, but international guidelines mention that when a patient has got interstitial lung disease, the threshold to perform lung transplantation is usually quite low. So we actually carry forward this statement, and that is what is seen. Now, as I mentioned, these are the two confirmed things. Lung cancer, unfortunately, it's a very gray area right now. We are having literature which is saying that you can use lung transplantation for lung cancer. Obviously, it has to be quite early in its stage, and there are special surgical techniques which is being used. There is very scarce data. There is no international guidelines which at the moment mentions, but 4 to 5 years down the line, we might be seeing advancements, and we might start including early stage lung cancer also into lung transplantation.
Thank you for this wonderful insight, the role of lung transplantation in these kind of end-stage lung disease due to heavy metal. So thanks a lot. One of the indications is lung cancer also. So early cancer lung, so we can opt for the lung transplantation also. Very nice. Thank you, Kapil. So we'll move on to Dr. Sunayana ma'am. How does long-term exposure to heavy metals affect lung function and contribute to the development of the respiratory diseases?
Manoj has said, the high heavy metals mainly have mechanism of damage, their damage by the oxidative stress and inflammation, disruption of cellular functions, and fibrosis in the lungs. So the lead, cadmium, arsenic, and mercury generate the reactive oxygen species and induce the oxidative stress and leads to inflammation and lung changes in the lung cells and the tissues. And heavy metals interfere with the cellular functions and including enzymatic activity and protein synthesis, leading to impaired lung function and tissue damage. And the chronic exposure to the heavy metals leads to pulmonary fibrosis and scarring and thickening of the lung tissues, which reduces the lung elasticity and impairs the breathing. Especially the cadmium and arsenic are associated with the COPD and by oxidative damaging the lung tissues. And asthma is associated with heavy exposure to mercury. And lung cancer have been found to be associated with the cadmium, arsenic, and interstitial lung disease has also been seen in these heavy metal exposed patients.
Thank you, ma'am. The heavy metal exposure leads to sometimes restrictive lung disease, ILD, and obstructive airway disease like asthma and other things. There are a lot of exposure which leads to both. Sometimes we can get the mixed pattern also during the pulmonary function test. The mechanism behind this, the oxidative stress, inflammation, fibrosis, bronchiectasis, etc., etc. Thank you, ma'am. So we'll move on to Richa, ma'am. Regarding the chelating agents, already Dr. Manoj and Dr. Kapil mentioned about the role of chelating agents. So what adverse effects should be monitored when using chelating agents for metal toxicity treatment? Richa, ma'am.
So some of the common adverse effects is when we start these chelating agents, and basically there can be pain or irritation at the site of the injection. Some can have allergic reactions to it and angioedema or maybe chest tightness. That can be one of these. So you need to monitor the patients when you're starting first. And what basically chelating agents are doing, they are binding the toxic element and then it is eliminating through urine. So sometimes there is dyselectrolytemia, and so you always monitor electrolytes. You always monitor the renal function test because these can lead to nephrotoxicity also. And you also monitor the transaminases levels. You always monitor for hepatotoxicity also because some of them can cause that. One dreaded complication of chelating agents is that sometimes when there is elimination from the other tissues, but then it gets reversed and gets accumulated in the brain. So you always watch out for the neurological adverse effects also. But the primary thing that you watch out for is one is the electrolytes, the renal function test, and any allergic reaction in the first initiation of the therapy.
Thank you, ma'am. Thank you for this question regarding chelating agents. Very nice. Krishna sir put up message in our group. There are a total number of 1,211 logins. Yeah, good. Because this is a very rare topic, very dry topic also, one of them. So, need of the hour, we have to, as a specialist point of view, this topic we have to precisely diagnose and treat accordingly to prevent morbidity and mortality. Thank you, Krishna sir, for the wonderful comment and the opportunity to give an answer. Thank you, sir. And we move on to the Dr. Manoj. Role of interventions like bronchoscopy and thoracoscopy, to take the lavage and do the biopsies, transbronchial lung biopsy or VATS lung biopsy. So how effective is bronchoscopy and lung biopsy in diagnosis and monitoring methods for heavy metal exposure and its impact on lung health? Manoj, sir.
Yeah. So I think after having taken a very good clinical history and seeing the patient from literally from hair to toe, right? Everything for after suspecting the patient who is exposed to heavy metals. Now, as chest physicians and with a lot of
You're muted, Manoj sir. Again, you muted. Just unmute, sir. Yeah, fine.
So we cannot forget bronchoscopy, and especially to have a proper diagnosis. So actually, when we do bronchoscopy, it is usually when we suspect there are features of ILD on the HRCT chest, or there are some PFT abnormalities, and we need a diagnosis. There are no specific pathology except for patients, specific histopathological diagnosis, except for cobalt exposure patients. So in patients who are exposed to cobalt, there is a presence of cannibalistic multinucleated giant cells in the bronchial lavage, and this is diagnostic in the appropriate setting. And this pathology is known as giant cell interstitial pneumonia. Apart from this, there is indium tin oxide exposure, which causes lung disease, and there is a strong correlation. And these patients may have ILD or pulmonary alveolar proteinosis. In both ILD and pulmonary alveolar proteinosis cases, in patients who are exposed to indium tin oxide, indium was identified on lung biopsy with particles visible under light microscopy. And common pulmonary histopathological features in these patients included intraalveolar exudate typical of alveolar proteinosis, cholesterol clefts, granulomas, and fibrosis. Apart from these two, there are other metals with specific histopathological evidence. Like patients having aluminum exposure, there will be increase in bile cells. In patients who have arsenic exposure, there will be elevated lung dry weight and collagen deposition in the lungs. Cadmium, septum cell thickening with alveolar lung inflammation. In patients with uranium exposure, there will be neoplasia, fibrosis, lung biopsy with UIP pattern of fibrosis, and vanadium, collagen deposition, airway smooth muscle cells. Apart from these, a good number of patients may have malignancy also because of exposure to heavy metals.
Yeah, thank you. Role of biopsy using bronchoscope and thoracoscope. Diagnosis. Sometimes we deal with a malignancy. So the metal exposure which leads to malignancy also one of the common etiological thing we come across.
A lot of non-small cell carcinomas are linked to heavy metal exposure.
Correct. Heavy metal exposure leads to a lot of issues, infection, inflammation, neoplasms. So we want to keep it in mind in a broader way, so we don't miss anything. As a specialist point of view, necessary we go and take the tissue and see pathologically what kind of a pattern, what kind of celluloid material and all. So thank you, Manoj, for this wonderful insight.
Mass spectroscopy can also be done, but that is more of like not in a routine.
We are not doing that. Okay. There is a chat box question from Dr. Prasanna Kumar from Karnataka, Bangalore. Insight on common inhalation injury due to metals and management. Anyone can take the questions. It's already mentioned during presentation, and also Kapil also mentioned. Insight on common inhalation. What are the common inhalation injury due to metals and how to manage? Yeah, Richa, ma'am, you continue. Anyone?
I think that was the whole we were talking about. So different patterns we were discussing about the inhalation, and then if they want to ask that there are acute presentations also. Sometimes when someone is exposed to very high level of fume exposure, of metal fume exposure, they can present with pneumonitis, and even after hours or days, they can present with severe non-cardiogenic pulmonary edema. So that is one form, and then we have the chronic forms where we have highlighted in the talks also, in the discussion also, that from any part of the respiratory system, starting from the upper respiratory tract, the larynx, the nasal septal perforation, or maybe just laryngitis, pharyngitis. It can involve the airways causing COPD or asthma. And then in the alveoli, it can cause an interstitial, interstitial lung disease. So it can involve any form. That depends on what kind of metal the patient is exposed to, and those particular patterns will be there. So acute and chronic, there are two forms.
Thank you. Thank you very much, madam. So we are at most we are nearing the closing of this thing. For the past 1 hour, we discussed in detail about the metallic lung diseases. So immunopathogenesis, clinical presentations, and how to diagnose, starting from clinical, radiological, pulmonary function-wise, pathological, and role of interventions, and role of lung transplantation and all. So I learned so many things. I think almost delegates also learned so many points about this metallic lung diseases. Now I request all the esteemed panelists, you can give the 1 minute take-home messages about the subject of metallic lung diseases, so preventive aspect, treatment aspect, anything you can tell. So starting from Dr. Manoj, sir. Take-home messages from this topic, Manoj.
So having talked about metallic lung disease or heavy metal exposure, what I would like to say is that when we suspect heavy metal exposure, we suspect a patient suffering from that, and if we take a biopsy, lung biopsy, either TBLB, cryo, or whole lung biopsy, then we need to talk to the pathologist to specifically look for changes specific to the metal which we are suspecting, so that they can actually give more time and see specifically. That is going to be of help, rather than just sending the biopsy. That would be my take.
Yeah. We have to be friendly with the pathologists and discuss what we want exactly. This is a very, very important. And the same, similarly, radiologists also. So what kind of a pattern is it radiologically? So we have to be, go to the radiology room and discuss with the radiologists and pathologists. It's very, very important to arrive at the correct diagnosis. Thank you. Kapil, you will take your messages from this topic.
So first of all, it was a very unique topic, to be discussed. And while we've had an excellent discussion on this topic, remember, this is a very pointed discussion. My take-home message is, trust me, when we see these patients clinically, it is very hard to diagnose. Let us not kid ourselves. You need to have a very high index of suspicion. And according to me, there are two things which will be my take-home message. Number one, you need an excellent in-depth history, which has to be taken in, you really need a lot of time to spend with these patients. And second is, not only the lungs, but you need a very detailed systemic clinical examination to have, at least something which is going towards a toxic metal, exposure. So once you cover these two things, I think things will start being unfolded in due course of time. So that will be my take-home message.
Thank you. Richa, ma'am, your take-home messages.
I completely agree with others that a high index of suspicion, always taking occupational history and asking about everything about the detailed history is of paramount importance. Otherwise, if you don't engage in that history, we'll tend to miss the diagnosis. So that is very crucial. And the history, and anytime when even in COPD, if there is no common risk factors or common this trigger is there, or if in your ILD patients, if you are not finding, before labeling any patient as idiopathic or intrinsic, always look into their occupational history and try to find out if there is any kind of exposure that can lead to these diseases, instead of labeling just the patient as idiopathic. And then definitely when going for the diagnosis, whenever required, go for wherever you can find a specific definitive diagnosis, that is better. So if you're planning the biopsy, as said by sir also, always discuss with the pathologist you are suspecting a metal toxicity. also, so that they can also read the pathology accordingly.
Thank you, ma'am. Thank you.
Thank you.
Your very good take messages. Move on to Dr. Sunayana, ma'am. What is your take messages from this metallic lung disease?
So same as the Dr. Kapil said, it is very important to take a detailed, good history and systemic examination and good general examination from head to toe for the clinical changes like dermatitis, skin changes, nail changes, and all.
Thank you very much, all the panelists, Dr. Sunayana ma'am, Richa ma'am, Dr. Kapil, and Dr. Manoj sir, for this wonderful time. I learned a lot of things from this presentation, preparation, and all. So thank you all for this wonderful thing. The take-home messages from my side, same only. High index of suspicion, each and every patient. This is very, very important. Meticulous, detailed history, mainly the occupational history is very, very paramount important. And the clinical examination, starting from head to foot, systemic examinations, apart from the lung, you have to examine thoroughly, even the nail, skin, everything. And appropriate investigations like pulmonary function test, 6 minutes walk test, and HRCT scan, and sometimes the biopsy. Tissue is the issue. So biopsy to pinch a diagnosis, rule out other causes like infections and other malignancy and all. So this is a varied presentation. This metallic lung diseases, it can present as pneumonia, present as ILD, present as asthma. There is a restrictive and obstructive pattern. So we have to clinch a diagnosis. We are all practicing in the era of precision medicine. Nowadays, we have to diagnose precisely and treat precisely to prevent unnecessary morbidity and mortality. So thank you very much for this wonderful evening. I thank you, CCI team, Dr. Krishna sir, Nanana sir, and our president, Dr. Ashish Dubey sir, and Secretary, Dr. Anil Maske, Vijay Kumar Chetty, our CCI webinar coordinator, Dr. Shivani ma'am, Dr. Kiran, all the pillars of our CCI. Thank you very much for this wonderful opportunity in this platform. Every Thursday, we are learning so many things. So we're doing human services. So God bless. Long live CCI. Thank you very much. We'll meet again on next Thursday. Thank you. Thank you all.
Thank you.
Thank you.
Good night.
Thank you.